Just a couple of housekeeping things before I get started, and I think a lot of the other speakers will do this as well. We don't intend to cover the entire spectrum of, for example, GI medicine. We're going to really try to focus what's in your handouts and on the slides, focusing on what's probably most relevant for the board exam. Now, the other thing is, I'm not going to read word for word what's on the slides. I'm going to assume that you guys are going to go through the slides, so I'm going to try to highlight the most important things. And in some areas where things are particularly important, what I've done, and I think what a lot of other people have done, is on the slides, what you'll notice that they're bold print, they're red, they're underlined. If you see any of that stuff on the slides, then circle it, highlight it on your syllabus, because I think that represents really high risk for showing up on the board exam. In general, I would say things that are quadrads, things that are triads, those make for really great questions on the board exam. And also, anytime somebody mentions that this or that is the most common cause of whatever, I think they still like for you to know the most common causes of this or that, so I would circle it and highlight that also. I think this slide can probably summarize the mindset of the ABEM examiners as we go through this. The caption here is, "He couldn't find a thing wrong with me, the quack." And here's a woman walking out of a doctor's office. For the purposes of the boards, please assume that every patient you see is about to die. And it's up to you to try to figure out what is going to kill that patient and work backwards. So just like we've learned in residency, you've got to think about the worst case scenario first, not the most common causes of different things. So on that board exam, if somebody's got a little bit of queasiness and nausea, it's not the flu, it's a STEMI for all intents and purposes. If they've got a little bit of abdominal pain or maybe some back pain after lifting something heavy, they're rupturing their AAA. If they've got flu symptoms, think about, anthrax, okay? And if they've got stable vital signs, they're actually in occult shock. So you've got to really have a healthy degree of paranoia as we go through this. When we get to the cardio section, I always tell people, if they present a case to you, here's Mr. Jones, who just finished this meal of some spicy jambalaya, and now he's got epigastric burning, belching, dyspepsia. He leans back, it feels worse. He sits upright, it gets better. He takes Maalox, his pain goes away. The diagnosis is STEMI. That's exactly right. All right, so really maintain a healthy degree of paranoia. All right, so what we're going to do is we're going to start at the top, and we're going to work our way all the way to the bottom of the GI tract and focus again on what kind of things you probably most need to know, starting with dysphagia. There's a lot of different things that can produce dysphagia. Most of them are mechanical type of problems, upper or lower GI mechanical type of problems that we'll just touch on. And in terms of your workup, barium swallows or some type of esophageal swallow is going to be good. You think about cancer, of course. But again, on the board exam, you're going to think about some neuromuscular problems. For example, strokes that give you bulbar muscle palsies. Botulism can give you some difficulty swallowing. Myasthenia gravis, cranial nerve palsies. So think about some of the less common but really deadly causes of dysphagia as well. Of course, the more common types of things are mechanical. Zenker's diverticulum, that's a very medicine-y type of thing. A thyroid goiter can push backwards on the esophagus and give you some dysphagia. But again, think most intently about some of the real deadly causes. You can get proximal obstructions, you can get distal obstructions. Distal obstructions are more common, very typically associated with improperly chewed meat, and I think that's no surprise to anybody who's working regular shifts in the emergency department. Schatzky's ring and so on. So again, think about mechanical as most common, but do think about those neuromuscular type of problems as well. Esophageal rupture, or rather I should say esophageal injury, there's two major things to worry about. There's Mallory-Weiss, which typically is the retching, vomiting patient with small streaks of blood in their emesis. That usually is just a submucosal or mucosal type of tear with small amounts of blood. In contrast to esophageal rupture, that doesn't actually typically give you blood in the emesis, but it can give you terrible abdominal and especially chest pain. It's one of the can't-miss causes of chest pain, and be on the lookout for esophageal rupture and that Boerhaave syndrome, which is on the next slide. Again, esophageal rupture, we don't see it all that often. In the year 2019, what's the most common cause of esophageal rupture? It's not the Boerhaave syndrome, it's the mechanical or the person who had the recent invasive procedure. The patient comes in and says, "Doc, yeah, I had an endoscopy yesterday." Or I've even seen one case of a very aggressively placed NG tube, believe it or not, that produced an esophageal rupture. So think about esophageal rupture. Not everyone in real life has the classic Boerhaave syndrome, but on that board exam, you've got to be on the lookout for it. In my career, I've seen Boerhaave syndrome probably about 12 times. 11 were on the boards, all right? So you've got to be thinking about Boerhaave syndrome, okay? Anything that's classic, I think in Latin, classic can be translated to it shows up on the boards, but not in real life. It shows up in the textbooks. So think about Boerhaave syndrome. And again, that ABEM, that population of patients that lives right around ABEM General Hospital is a very, very unusual patient population. They're a bunch of retching, vomiting alcoholics, and usually they're driving motorcycles during late pregnancy with no helmets, and invariably they refuse blood transfusions also. So keep in mind. So anyway, Boerhaave syndrome, just a couple of extra words on this. Again, this is the classic retching, vomiting alcoholic. They're vomiting against a closed glottis and they blow out their esophagus. Up here it talks about left posterior distal location of the rupture. I don't think you need to worry about that. But what you should remember is Boerhaave's and esophageal rupture is full thickness. Mallory-Weiss is just partial thickness. It's mucosa and submucosa. Boerhaave's usually doesn't give you bloody emesis, but instead it gives you severe chest pain. There's that Hammond's crunch, that Rice Krispie kind of feel and sound when you listen to their lungs. If you want to work it up, you can do an upper GI series, not with the barium, because it's going to go through the esophageal hole, right? You can use a water-soluble contrast, or go to right to CAT scan. On that board exam, what you probably ought to look for also is subcutaneous air. And let's see if I can get this. If you look up there in the neck, you'll notice that subcutaneous air in the soft tissue, and that's a classic finding associated with Boerhaave syndrome. And as a general point, with any x-rays or imaging in general, but especially with x-rays that they give you on the exam, make sure to look at the entire image, all right? If they give you a chest x-ray, don't just look at the lungs. Look at the soft tissues, look at the bones, look at the clavicles, because there might be something else that tips you off to the answer. And the answer here lies in the soft tissue, that subcutaneous emphysema, all right? Now, there's a few locations where foreign bodies tend to get stuck as they get swallowed. In adults, almost always it's at the lower GE junction, but in the ped section, you might hear more about this in the ped section, but pediatric patients, they can get esophageal foreign bodies stuck in other locations also, and there's 4 typical locations that they always talk about as the most common places where foreign bodies get stuck. Number 1, cricopharyngeus muscle, which is at around C6. Number 2, at the aortic arch, which is at around T4. At the tracheal bifurcation, which is at T6, and then of course at the gastroesophageal junction at around T11. Coins tend to show up there. In my career, I've seen probably about a half dozen coins that go down the wrong way, or actually they shouldn't go down either way, but they tend to be esophageal. And when they're esophageal, what you're going to see is that the coin will be in the, as they say, en face orientation, as you see up here, the circular orientation on the AP view, whereas if it's in the trachea, it's going to be in the en face or circular orientation in the lateral view. And it actually makes sense if you think about it. If everyone looks up here for just a second, the esophagus is shaped like this, and so the only way the coin is going to go down is like this in the AP orientation, whereas the trachea has these C-shaped rings. Again, looking up here, the open end of the C-shaped rings points backwards, and so the only way for the coin to go down is shaped in this orientation. So you'll see the coin in the trachea en face in the lateral orientation, like what you're seeing here, whereas if it's in the esophagus, you'll see it like this. So if they give you an x-ray like this, and they say, is it the trachea or is it the esophagus, you'll know. If they give you this x-ray, and they say, is it the esophagus or is it the trachea, then you'll know that as well, just simply based on how the coin gets down there. All right. What do you work them up with? Well, CAT scan is probably the easiest thing to do. You can get contrast studies, and if you have a foreign body, when do they need to come out? That's going to be another thing that you need to know, and I've highlighted this. There's certain, almost all foreign bodies will eventually pass, but the exceptions where you need to get GI to come in and take them out right away are if they're stuck in the esophagus, Or if they're large, how large? Probably if they're greater than about 2 or 3 centimeters in size, they won't pass through the pylorus. So they'll probably need to come out. And also, of course, if they're sharp or pointed, if somebody's swallowing a nail, and especially if it's stuck in the esophagus or glass objects, if you just let them transit through the GI system, they're going to rip it up. They're going to cause a lot of GI bleeding. So if it's sharp, they need to come out right away. All right? Button batteries are a special case that you've really got to pay attention to. Button batteries cause a lot of morbidity. If a button battery is stuck in the esophagus, it's got to come out right now. Right now. 2 o'clock in the morning, you're calling GI to come in, and they need to take it out right now. A lot of other esophageal foreign bodies, maybe you can give it a little time, and maybe it's going to pass down to the stomach. And once it makes it down to the stomach, almost always small things will pass through the system and be okay. But button batteries, no way you're waiting. They've got to come out right now. And the reason is that if an esophageal, if a button battery gets stuck in the esophagus, it can actually start cooking or frying the esophagus. In fact, there's some very interesting videos that have been posted on YouTube. One of them was from the Maryland Poison Center, where what they did was they took a button battery and they just stuck it in a raw hot dog, and they videotaped this without doing anything. They just videotaped it, and over the course of about half an hour, the hot dog started burning in the area of the button battery. You actually start getting current, and it starts cooking the meat. And remember, the esophagus is meat, as is the trachea as well. So if the button battery is in the esophagus, you've got to get that thing out immediately. In fact, go ahead and start broad-spectrum antibiotics right off the bat while you're waiting for GI to come on in. All right? Now, if the button battery does make it down to the stomach, in that case, you can probably let it go, get serial x-rays over the next couple of days, have the parents fish through the poop to make sure that button battery passes, because if it does make it down to the stomach, it's probably going to keep on moving, not get lodged, but keep on moving, and it'll, generally speaking, it'll pass safely. But again, if it's stuck in the esophagus, it's got to come out immediately. Get GI to come on in. Right? When things are truly stuck in the stomach, what are your options? Well, the main option, again, is going to be to get GI to come in and see. Sometimes people talk about using some glucagon. If things are stuck in the lower esophagus, like that improperly chewed meat, glucagon relaxes the lower esophageal sphincter. It might help it pass. I've seen that work rarely, but it's worth a try. Sometimes people talk about nifedipine. It's a smooth muscle relaxant. It's probably about the only time we ever use nifedipine in the emergency department, and I've heard some people say that that occasionally works. Some of our more senior nurses like using carbonated beverages, give them some soda, and that sometimes works a little bit. Back when I was in residency, people used to talk about using a Foley, where you actually pass the Foley down and then blow up the balloon and slowly pull back on the Foley, and presumably it'll pull the foreign body out. But then there was cases where it would come out to the posterior pharynx and then drop into the trachea, and so that didn't work out too well. So that's no longer recommended. Forget the Foley technique. And people also talk about if it's an improperly chewed meat, give them some papain, which is a meat tenderizer. Well, that's out also because people realized, hey, the esophagus is also meat. So it was increasing the risk of perforation there. So don't bother. If you want to try glucagon or nifedipine, fine. Otherwise, just go ahead and call GI. I'm not going to say a lot about caustic ingestions because you'll hear more about that in the tox lecture, but in general, if somebody ingests a caustic substance, your job is to simply maintain hemodynamic stabilization, secure the airway if needed, and have GI come in to scope them and try to figure out how much damage there is. On this slide here, you'll see a little something about dilution, using water or milk if it's alkali ingestions, and that's a little bit debatable. Again, I'm going to turf that to the tox lecture, but in general, the key thing that I just want to say is that because caustic ingestions can cause so much damage to the esophagus and posterior pharynx, maybe even dropping into the airway a little bit, the most important thing you can do is just manage their ABCs and then get GI to come in and scope them. There are a lot of chronic complications that can develop. Some acute, some chronic, and so, again, just manage these patients hemodynamically. All right, moving down to the stomach now. What do you need to know about the stomach? Again, this is very clinical. Most everybody deals with peptic ulcer disease all the time. Key thing I've highlighted up here, the most common cause of peptic ulcer is H. pylori, and the current recommendations are, if you suspect somebody having peptic ulcer disease, the current recommendation is to still initiate them on a 4 to 6 week course of H2 blockers. And if that doesn't work, then they're supposed to go to GI for H. pylori testing and treatment with antibiotics and everything else. Now, I know a lot of people here probably, if you have a strong suspicion for H. pylori, you just jump right to giving them the antibiotics and the PPI and so on. And clinically, that's probably fine. But if you were to get a question about what's the first thing you do if you suspect H. pylori, the recommendation is still a 4 to 6 week course of an H2 blocker. All right? Enough said about that peptic ulcer disease. We'll talk a bit more about GI bleeding, and there's just some terminology here. Hematemesis refers to blood from above. Hematochezia is bright red blood from below. Melena is that dark, tarry blood from below, which almost always is associated with an upper GI bleed. It turns black because of some digestion. There are some other things that can produce a black-looking stool. Pepto-Bismol can do it. Iron supplements can do it, all right? But usually it's not that tarry and foul-smelling type of stool that we're accustomed to seeing when patients have upper GI bleeds. Right? There was one article on from the LLSA ratings that talked about distinguishing between upper versus lower GI bleeds that I just wanted to spend a moment on. What are the predictors that the patient with the GI bleeding has an upper GI bleed? Well, number one, if there's melena. We mentioned that a second ago. Number two, if you put an NG tube in, and that's not necessarily real common anymore, but if you put an NG tube in and you lavage and it doesn't clear, or bright red blood continues coming out, then that obviously points towards an upper GI source. And the third one, which is worth remembering, might be even highlighting because it's not intuitive, is that because upper GI bleed tends to get digested, the BUN tends to rise without the creatinine rising. So if you see a BUN to creatinine ratio greater than 30, that points towards an upper GI source. And I think that makes for a great question, so I'd actually highlight that as well. BUN to creatinine ratio over 30 points to upper GI versus a lower GI source. What are the negative predictors of upper GI? Well, if you see bright red blood in the stool, almost always is lower GI. And sometimes the GI consultants will say, well, it could be a rapidly transiting upper GI bleeds, and that's why they want you to put the NG tube in. But in the reality, if somebody has an upper GI bleed which is so profuse that it's still bright red when it comes out the bottom, invariably those patients have pretty significant exams, a lot of tenderness, and they oftentimes tend to be very unstable as well, hypotensive, or at the very least, fairly tachycardic. All right. What are the predictors that a patient with upper GI bleed needs to get endoscopy right away? So again, it's 2 o'clock in the morning. Do you need to call the GI or endoscopist to come in right away? What are the indicators that they need emergent as opposed to just urgent? Emergent treatment. Well, number one, again, if there's continuing red blood output from the NG tube lavage, or if they're hemodynamically unstable, if they're persistently tachycardic, if they're hypotensive, or if their hemoglobin has already dropped below 8. And those are usually the patients that you're already starting on transfusions. In those scenarios, that requires an immediate upper GI evaluation. And then there is a decision instrument called the Blatchford score, which has been studied and validated and found to predict which patients do and which patients do not need urgent intervention. And I can't imagine that they're going to ask you all the different components of the Blatchford score. You might want to just take a quick look at it on MD Calc or on the internet. Again, I think it's important to simply know that there are decision instruments that help you decide and help predict which patients need to go. And the Blatchford score, the Blatchford score is probably the most popular and the most studied and well validated. All right. Let's talk a little bit about upper GI bleeding in particular, then we'll move down to peptic ulcer disease, especially duodenal. This is the most common, again, most common I've highlighted, most common cause of upper GI bleed. Other things, gastric erosions, NSAIDs, Mallory-Weiss tears. During late pregnancy, esophagitis can become a common cause of upper GI bleeding. Usually it's relatively mild, it's not profuse. But if they were to give you a question where a pregnant patient has mild amounts of upper GI bleed, first thing to think about is going to be esophagitis and duodenitis as well. Now, what are the things that we do for these patients in the emergency department? Well, I know most everyone here, including us, where I work at University of Maryland, somebody's got an upper GI bleed, we put them on a PPI, and then we put them on octreotide. We might even give them antibiotics. What does the literature actually say that you need to know for the board exam? First point, PPIs and H2 blockers, when started in the emergency department, are not associated with any significant difference in outcome. So I know many of us will do it, the GI folks like it, but the Cochrane database indicates also that there's no benefit from early initiation of those PPIs. So if you were to get a question about what are the things that work, it's not PPIs or H2 blockers when started in the emergency department. Octreotide does have evidence. Octreotide can be useful at decreasing the amount of bleeding and the number of subsequent transfusions that are needed for variceal bleeding. Not for others, but if it's a variceal bleed, octreotide does have evidence. And back when I was in residency, back when many of you were in training perhaps, vasopressin was often used. Vasopressin's largely fallen out of favor because, number one, it didn't change outcomes very much. And the other problem with the vasopressin is that it produces not just GI vasoconstriction, but it produces diffuse vasoconstriction. So if you were to get a question that incorporated vasopressin, I think the key thing to remember is that because vasopressin can produce diffuse vasoconstriction, including coronary vasoconstriction, whenever you use vasopressin, you always have to also start that patient on a nitroglycerin drip in order to maintain coronary patency. So again, if they give you a question, this patient's getting started on vasopressin, what else do you need to do? You also need to put them on a nitro drip, all right? So, going back again, what are the things that work? PPIs and H2 blockers have not been shown to change outcome. Octreotide has been shown to change outcome in variceal bleeding. And then the one other thing to remember is that prophylactic antibiotics in cirrhotic patients with upper GI bleeds have actually been shown to improve mortality. The most common reason why cirrhotics end up dying when they present acutely is because they have bacterial translocation and can end up developing sepsis. So some studies have actually shown that if you put patients on, say, a third-generation cephalosporin to cover the enterics, just prophylactic antibiotics have been shown to actually decrease mortality in patients with cirrhosis who have upper GI bleed. So that would be, again, a great question because Cochrane database supports that as well. Any benefit to lavage? Probably no mortality benefit. Lavage can be helpful if you're trying to distinguish that upper versus lower, if we talked about. And also the Blakemore tube. Blakemore tube can be life-saving. How many people here have put in a Blakemore tube in the past year? So a couple people. Past 5 years. All right? Past 10 years. Okay. At ABEM General Hospital, you need to know how to put Blakemore tubes in. All right? Because somebody on that board exam is going to be bleeding out, and if you don't put that Blakemore tube in, they're going to die. For those new grads, next year when you take the oral boards, you may have to put a Blakemore tube in, and you may also have to describe how do you do it. So if there's anybody here, in particular the new grads, who have never put in a Blakemore tube, please learn how to put the Blakemore tube in. And you can do it in 5 minutes. Just go to YouTube. Honestly, go to YouTube or Google, punch in Blakemore tube, and you'll see a bunch of videos that in about 5 minutes show you exactly how to put a Blakemore tube in. I work at a big tertiary care hospital. We've got fellows in everything. Like there's a pylorus fellow and a right atrium fellow. It's ridiculous, right? But even at our place where we have access to all these consultants, I'd say at least once a year in our emergency department, we put a Blakemore tube in somebody in the middle of the night, and it's a life-saving procedure. So that's why I so strongly think you have to know how to use a Blakemore tube, especially for the board exam. Essentially, just real quick, Blakemore tube has 2 balloons. You see up there is this long, elongated balloon, and that, when blown up, compresses the esophagus. So if it's a variceal bleed, presumably this puts some compression against the bleeding varices. And then distally, there's the distal stomach balloon. And when that blows up, if the patient has an ulcer that's bleeding and they're spewing out for upper GI blood, that will hopefully help prevent the blood. It might tamponade the blood. More importantly, it helps secure the airway to some extent by preventing blood from coming out the top. Almost all the time, in fact, the only cases I've ever seen with Blakemore tubes, they're all intubated, all right? So you need to protect the airway. And then secondly, this really can be a life-saving procedure. So when you go back to your shop, make sure you know where the Blakemore tube is in your emergency department, and also just check out YouTube, know how to put a Blakemore tube in. And this can be life-saving when somebody has massive upper GI bleeding, and it buys you enough time often to get the surgery and GI consultants to come in and get that patient up for a life-saving procedure. All right? What about lower GI bleeding? Well, the most common cause of lower GI bleeding, well, let me rephrase that. The most common cause of blood on the guaiac card is probably an upper GI source, right? But if you see bright red blood from below, there's a few things to think about. You want to think about cancer. You want to think about angiodysplasia. Definitely think about diverticulosis, especially in older patients. This can be painless, massive GI bleeds that are on and off, and this is a big part of the reason why just about everybody with bright red blood from below, even though it stops, all right, if you're worried about diverticulosis, they've got to come into the hospital because otherwise they go home and they rebleed and it can be massive and life-threatening. And then at the bottom, I've made mention of aortoenteric fistula. We'll talk more about that briefly tomorrow. But an aortoenteric fistula typically is going to be in somebody who's had a previous AAA repair who now comes in with the GI bleed. Presumably the fistula has formed between the aorta repair site and the GI system. The most common location of an aortoenteric fistula is the duodenum, and the reason that's important is because it means that the patient can have upper or lower GI bleeding. So on that board exam, if any patient comes in with a history of a previous AAA repair who now comes in with any GI bleeding, upper or lower, that's an aortoenteric fistula until proven otherwise. In fact, if you're reading through the question and they say this patient's had a previous AAA repair, just drop down to the answers and pick out GI bleeding and aortoenteric fistula. Because I can't imagine there's any other reason they would tell you that this patient's had a previous AAA repair unless it is an aortoenteric fistula. All right? Now, in terms of discharge home, is it possible that somebody can be discharged home after a GI bleed? Yes, it's possible, but very rare. This is the generally accepted criteria to discharge home somebody who comes in with a GI bleed. And this is enormously difficult to meet. No comorbid disease, normal vitals, negative or trace blood only on the guaiac. In other words, if it's bright red blood, they fall out of this. Negative GI aspirate if done. They have a normal H&H, good home support, understanding signs and symptoms of significant bleeding, follow-up arranged in 24 hours. These are the type of criteria that need to be met for somebody to reasonably be sent home. And so I think on that board exam, pretty much all of your GI bleeds are going to need to come in to get a rapid evaluation. All right, we'll take a little mental break here. I like collecting signs, and people always send me signs from all over. This one's from Seattle. And we should have this in every city, right? Drive carefully. We have 2 cemeteries and no hospital, right? And I don't know what city that is, nor do I know what city this is, but I can think of a few cities probably that this ought to be. All right. How are we doing with time? All right, let's keep marching forward. We're going to talk about the hepatobiliary system and bilirubin. Most of the bilirubin stuff is more medicine-y, but there's some very basic things to think about with bilirubin. There's 2 types of hyperbilirubinemia. There's indirect hyperbilirubinemia, and there's direct hyperbilirubinemia. Indirect refers to increase in unconjugated bilirubin, and the most common causes are things like hemolysis and decreased conjugation, like sepsis and Joubert syndrome. The majority, I think, are hemolysis. So think about hemolysis when you're dealing with indirect bilirubin. The majority of cases of direct bilirubin are obstructions. So that's the patient with stones. Sometimes you can get obstructive sources that are associated with cirrhosis and sepsis, sometimes CHF. But the way in my mind I separate these two is unconjugated or indirect bilirubin mostly is hemolysis, and then conjugated or direct bilirubin is mostly obstruction. And there's a lot of different things that produce obstruction. And that's how I simply separate these 2 out, and it saves me having to memorize all these different things. All right? Bless you. In terms of hepatitis, there's multiple types of hepatitis. Alcoholic hepatitis, there's toxin-related hepatitis, there's a viral hepatitis, which we will get into in just a minute. Key thing that I've highlighted down here, when you're working up patients with hepatitis, the most important lab marker of severe liver dysfunction is your INR. All right? The most important clinical marker of liver dysfunction is mental status, encephalopathy. All right? But in terms of your labs, it's all about the INR. There's no particular bilirubin which well correlates with the severity of liver injury. We've sent people home with bilirubins of 20, with total bilis of 20 or so. The INR is the key. All right? Okay, let's talk about some of the viral hepatitises. And largely this has been pestering us since probably USMLE 2 and 3 and in-services. It's still out there for the board exam. You've got to know viral hepatitis A and B and C, and we'll just touch on some of the other types of viral hepatitis as well. So viral hepatitis A, this is typically associated with fecal oral transmission. I think every year or two we hear about some type of hepatitis outbreak in association with some restaurant chain out there. For those people here that do international work, I'm sure a handful of you do, you know that this is a bigger concern in third world countries as well. And for those people that do that, there is a prophylaxis, the Hep A vaccine. If there's a household contact who gets diagnosed with Hep A, you can also give the immune globulin to other household contacts. Key thing there that it has to be given within 2 weeks of exposure. So if the patient comes in, or a patient comes in and says that their family member was diagnosed with Hep A after some recent international trip, if it's within 2 weeks, by all means, they qualify for the immune globulin. Hepatitis B has been a source of a lot of confusion because of all of these markers. We'll get there in just a second. So this tends to be percutaneous or parenteral or sexually transmitted. So keep those things in mind. Incubation can be quite a bit longer than with hepatitis A. About 10% of these patients can develop chronic hepatitis or chronic liver dysfunction. Hep C is a lot worse. We'll get there in a second. But Hep B, about 10% can go on to develop chronic problems, including cirrhosis, liver cancer, or carrier state. And then there's those pesky markers that you've got to worry about. Hepatitis B surface antigen is indicative of an active infection. It usually comes on early, and then once you develop immunity, it goes away. In fact, there's a little window period where it goes away, and then immunity develops a little while later, all right? So what I recommend that you do is when you see Hep surface antigen, just substitute the term active infection, all right? Hepatitis surface antibody, substitute the word immune. So common sense would dictate that you can't have surface antigen and surface antibody at the same time. You either have active infection or you're immune, one or the other. All right? You may get E antigen, and the only thing that E antigen means is that you are actively infective, but you are highly actively infective. And then there's core antibody, and core antibody means that at some point along the way you were once infected. All right? It doesn't mean anything about immunity. It simply means that you were once infected. So let me give you a couple of scenarios here. If you have Hep surface antigen positive and core antibody positive, what does that mean? Well, core antibody positive means that you were once infected. Surface antigen, substitute the term active infection. So this might be a chronic carrier. This is a person who's actively infective and they were once infected. All right? If they give you E antigen, of course, all you need to do is remember that it's very infective. What if they give you core antibody positive, surface antigen negative, and surface antibody positive? Well, core antibody means they were once upon a time infected. Surface antigen negative, they're no longer infective. Surface antibody positive, they're immune. So they got infected at one point and now they're immune. Great. What if I gave you a surface antigen negative and core antibody negative and surface antibody positive? What does that mean? They got vaccinated, right? Surface antibody positive means they're immune. Core antibody negative, they were never infected. How can you be immune and yet you were never infected? You got the vaccine. All right? So if they give you questions where they throw in different markers and they want you to figure out what's going on, again, just simple substitution of these words I think can be very helpful at figuring out exactly what's going on. Just substitute the words that are in red there. All right? The other type of scenario I would imagine you would get on the board exam is, let's say you're working in the emergency department and a nurse or tech upstairs got stuck with a needle from a patient who has chronic hepatitis B. So they're going to come down to the emergency department. What do you do for them? What you do is you need to draw their titers. If their titers for Hep B are appropriate, you're done. They're immune already. You don't need to do anything. But on the other hand, if their titers come back negative, what it means is that if they never got the vaccine or they didn't respond to the vaccine, So if their hepatitis B antibody titers come back negative, you need to restart the vaccine and give them a shot of immune globulin. All right? So if the patient comes down after being stuck with the needle from a source patient, hepatitis B positive, draw their titers. If the titers are positive, that they are immune, you're done. But if they're not immune, give them the immune globulin and then restart the whole series of vaccines there. All right? Simple enough. Hepatitis C. Hepatitis C is a big ticket item for sure. I mentioned a few minutes ago that hepatitis B, 10% develop chronic problems. Hep C, 50% develop chronic problems. So this is a much bigger issue from a chronic standpoint. They can develop chronic cirrhosis and also cancer. There is no effective vaccine. There are, as you see on TV, there's therapies that are starting to come out, but right now we don't have an effective vaccine yet. And if you get stuck with the needle, that was being used in a Hep C patient, your risk of seroconversion is about 2%. If you compare that to HIV seroconversion rate is about 0.3%. This is about 10 times higher than with HIV. And so it's no surprise that a lot of people worry more about Hep C, contracting Hep C when they get stuck with the needle, than contracting HIV. Again, 0.3% for HIV, 2% for hepatitis C. There's a few other types of hepatitis that you need to know also. Hepatitis D. Hepatitis D can only infect you if you also have B, right? You can't get hepatitis D by itself. Hepatitis D can infect you if it travels with Hep B or if you already have Hep B. And a key thing to remember here is that Hep B plus D is far worse than B alone. So that's about all I think you need to know about Hep D. It primarily occurs only if you have Hep B also. There's a hepatitis E, which is more common out in other countries, Asia, Africa, Russia, a Hep G as well, which you can get through blood transfusions. And then at the bottom, who needs to be hospitalized? Well, again, the lab marker, the most important lab marker is the INR, and then the most important clinical marker is encephalopathy. If they have encephalopathy, they're coming in. If their INR is rising, they need to come in. There's no specific bilirubin. Out here it says bilirubin over 20, and that's kind of shaky. In most hospitals, if the bilirubin is actively rising, they get admitted, but as soon as it peaks and starts falling, they get discharged. So I've seen patients, again, discharged from the inpatient hospital, inpatient units with bilirubins of 20 or 25, but if they're on the way down, they're good to go, all right? But encephalopathy and INR are the most important things. And then you've got all your others, if they're toxic in appearance, if they're immunocompromised, and so on, all right? And then there's a nice little mnemonic. Just remember the things that can precipitate hepatitis or hepatic encephalopathy. The mnemonic is liver, Librium, infection, volume loss, electrolytes, red blood cells in the gut. And ammonia levels are probably the most widely used laboratory marker predicting hepatic encephalopathy. You want to make sure that their glucose is okay. How do you treat these patients? Well, go ahead and start them on neomycin and lactulose, and then just support their ABCs. There's some other recommendations about low-protein diet. Again, that's not something that we necessarily need to worry about too much in the emergency department, but at the very least, if you diagnose patients with encephalopathy, start them on the neomycin, start them on the lactulose, and manage their ABCs. All right? Spontaneous bacterial peritonitis. There's only a couple of things that I've highlighted on this slide. Number one, you've got to know the bugs. The most common bugs, no surprise, they're gram-negative enterics. E. coli and Enterococcus, which can very easily be treated with cephalosporins. Even a first-generation cephalosporin is very nicely effective against these bugs. There's no big resistance that we're hearing about, so just start them on a cephalosporin. And then the other thing to keep in mind, if you do a paracentesis, what constitutes a positive paracentesis tap? The number that you need to look for is more than 250 neutrophils per microliter, all right? 250 is your magic number. It's not a lot. Right? If they tell you that the fluid looks cloudy, then almost always that's positive as well. But I think they would probably ask you about that count, and the magic number is 250. And then there was one LSA article that was signed for reading just several years ago. This is from the New England Journal, and so I think that this is pretty good grounds for board exam questions as well. This article was about liver failure, and so I've highlighted a handful of things up here. I'm summarizing this entire article with one slide. Number one, the most common global cause of acute liver failure, Hep A and Hep E. All right, that's global. In the U.S., the most common cause is acetaminophen toxicity. But globally, don't undervalue the importance of Hep A and also Hep E. We don't see much Hep E at all in the U.S., but worldwide, Hep A and E are the most common causes, all right? I'm going to turf the treatment issues with acetaminophen to the tox section. You probably know that already, acetylcysteine. Most common cause of death in acute liver failure is cerebral edema and intracranial hypertension and herniation, right? What can you do to treat intracranial hypertension from liver failure? Hypertonic saline at the bottom, mannitol, and also the article mentioned indomethacin, which works through some other mechanisms, and that's certainly not intuitive. Hypertonic saline and mannitol, yeah, we know about that, but add indomethacin also. These are the three treatments that they mentioned in the article for elevated intracranial pressure due to acute liver failure. All right? Okay, moving down to the gallbladder, right? Gallbladder pathology, again, something, there's no big secrets here, something that we see all the time. Stones are the biggest cause of gallbladder problems. Cholecystitis is almost always associated with stones. And what I've highlighted up here is that cholecystitis in the elderly really is considered a surgical emergency. And that statement will come right out of the surgery literature. You know, if you diagnose cholecystitis in a young, otherwise healthy 20, 25-year-old, what do? You know, you manage their pain, make sure they're tolerating POs. A lot of times, surgery will plan on doing an outpatient cholecystectomy in the next several days. Maybe you put them on some antibiotics to, quote-unquote, cool down the gallbladder for a few days, and then maybe they'll get their cholecystectomy in the next 5 to 7 days or so. In the elderly, no way are you waiting. Studies have shown that elderly, because of atherosclerotic thinning and weakening of the gallbladder wall, elderly can perf or develop gangrene within hours of a biliary obstruction. So if you diagnose cholecystitis, again, 2 o'clock in the morning, you're calling surgery in, you're prepping them and getting that patient ready for the OR. And again, that is not just my opinion, it's right out of the surgery literature itself, because they're at very, very high risk. So don't take chances on those elderly that have cholecystitis. All right? What kind of complications can you develop? Well, you can develop gallbladder gangrene, peritonitis. You can also develop a perf gallbladder and develop pneumobilia, or air within the hepatobiliary system. If they were to give you an x-ray, like this one up here, showing air in the right upper quadrant, there should never, ever, ever, ever be air in the right upper quadrant. If you ever see air in the right upper quadrant, that's one of two possibilities. It's either a perf gallbladder, also known as pneumobilia, or emphysematous cholecystitis. And that patient needs immediate operative treatment. The second thing that can give you air in the right upper quadrant, or air in the hepatobiliary system, is mesenteric ischemia. All right? And that's going right to the OR also. So if they give you an x-ray that looks like this, and you see air in that right upper quadrant, bam, you're done. You're calling surgery, that patient's NPO, and you're prepping the OR. They need to go right away. Because either way, either emphysematous cholecystitis or mesenteric ischemia, that patient needs emergent surgical intervention. All right? Now, the vast majority of patients with cholecystitis have gallstones. Only a few patients have acalculous cholecystitis. In the emergency department, there's probably only a couple of groups, 2 groups, that you need to worry about for being at risk for acalculous cholecystitis: elderly and diabetics. Now, in the real world, it's enormously rare. At ABEM General Hospital, it probably is not that rare. That you can have an elderly or diabetic patient that has cholecystitis and no stones. Right? So you get that ultrasound, you don't see any stones. Instead, you see some of the other signs of cholecystitis. The other people in real practice that get acalculous cholecystitis are patients that have been in the ICU for a week or two. Burn patients, burn ICU, or septic patients that have been in the ICU for a long time. So it's very rare that we see acalculous cholecystitis in the emergency department on arrival. The 2 exceptions would be elderly and diabetics. Right? And those patients have a much, much higher risk. Acalculous cholecystitis puts patients at higher risk of morbidity and mortality than calculous cholecystitis. all right? Be on the lookout for ascending cholangitis. Remember that Charcot's triad: fever, right upper quadrant pain, and jaundice. Again, triads, I think, make for great questions on the boards. This slide simply shows all the different locations patients can develop gallstones. Imaging for gallbladder, well, no surprise. Your imaging test number one, your imaging test of choice for the gallbladder is going to be ultrasound. Ultrasound's fantastic at picking up stones. It can also see other signs of cholecystitis, which would include thickening of the gallbladder wall, or pericholecystic fluid, or sludge. You can look for a sonographic Murphy sign. Right? But be aware that if a patient doesn't have stones, the ultrasound can sometimes be negative. So what's actually the best test for cholecystitis? The best overall test for cholecystitis is actually HIDA. HIDA is more sensitive at picking up cholecystitis. Ultrasound's the best test for stones, but the best overall test for cholecystitis is going to be HIDA scan. All right? So if you get that ultrasound and it doesn't show evidence of cholecystitis, but you still have a very high suspicion, you need to get the HIDA scan after that, all right? And this would be a great, a very simple ultrasound image that you'd get on the boards. And on the board exam, they are showing ultrasound images. So for those of you that trained back when I did, you might not be very comfortable with ultrasound, but there's some very simple images that are probably worth Google searching, and gallbladder ultrasounds are probably one of them, just to get comfortable. And they're not subtle. Right? What you see up here is you see evidence of a stone, maybe kind of sludgy in appearance. You see some echogenic shadowing below that. And you also see, take a look at that gallbladder wall. Normally the gallbladder wall is paper thin. If you see a thick gallbladder wall like that, that's considered thickened. 3 or 4 millimeters is too thick for the gallbladder wall. All right? Usually it should be just paper thin. Here's another example. Take a look up there. You probably won't get ultrasounds with letters and arrows on them, but this should be easy enough also. Take a look at how thick that gallbladder wall is, and there's a nice stone with some echogenic shadowing shooting down right below that. All right? So it's really not, even if you're not comfortable with the ultrasound, it's really not a difficult diagnosis to pick up. All right? Okay, moving to the pancreas. Again, very clinical. We see pancreatitis all the time. I know you do also. I'm not going to go through all the medical student details of pancreatitis. What do you need to know, though? There's a lot of different things that produce pancreatitis. Overall, most common cause is stones. Now, in the inner city, where I work, it's alcohol, for sure. Okay, and probably many places that you work, alcohol is still very common. But overall, the most common cause is gallstones. But there's a lot of other things. Tumors can do it. I've highlighted the word drugs. Please remember there's a few drugs that are associated with cholecystitis. Thiazides, estrogens, salicylates, acetaminophen, certain antibiotics. Please remember that there's certain viruses that can do it. Mumps and Coxsackie in particular. Then also hepatitis, adenovirus, and EBV. And also remember that there's some bacterial infections that can cause pancreatitis. Salmonella, strep, mycoplasma, Legionella. All right, notice they didn't put scorpion stings in here. I don't think they would get that on the board exam. But do remember that there's a handful of other things that produce pancreatitis as well. The best lab test marker is lipase, far better than amylase. We've pretty much entirely got rid of amylase. Lipase is more sensitive and more specific. Amylase is just so nonspecific, you could probably just get rid of it. Lipase levels also correlate more with the severity of disease. All right, plain films are for the most part useless. They often will, at most, give you just a little bit of an ileus pattern. And if you're lucky, you might get an ileus with some dilated loops right in the middle, right overlying the pancreas. That's oftentimes referred to as sentinel loops. All right? But plain films really are nonspecific. Just about anything can give you this x-ray. All right? Just about anything can produce an ileus pattern, and that's about it. Somebody with chronic pancreatitis may have calcifications all across the pancreas. So you may see you may see calcifications on x-ray all across the upper abdomen, but I don't, it's such a rare thing, I wouldn't imagine that they would give that to you. So x-rays are not all that useful. CAT scans are far more useful and far more diagnostic because they're a lot better at picking up pancreatic edema. So the imaging test of choice, if you need an imaging test, is the CT. Almost always, it's a clinical diagnosis, though. All right, and then I think most everybody remembers remembers the existence of the Rances criteria, probably the actual components. You've shifted to some gyrus way at the back of your head, back from medical school. Well, bring it back, at least for the board exam. The 5 Rances criteria at admission, I think, are probably worth remembering. The 48-hour Rances criteria, I'm not going to worry about. I don't think you should either. But the 5 at admission: age over 55, glucose over 200, white count over 16,000, AST over 250, LDH over 350. And the reason it's probably worth remembering these 5 admission Rances criteria is because studies have shown that if somebody arrives and already has 3 of these, then that portends a really bad prognosis. That person ought to be sent right to the ICU. We see so much pancreatitis, we get cavalier about it, but it's important to remember that there are some deadly complications of pancreatitis. And at least once a year, one of our chronic pancreatitis patients ends up going to the ICU, and we're all shocked to discover he died. You can die from ARDS, pancreatic necrosis, massive GI bleeding, DIC, but it's an important reminder that pancreatitis can be a morbid disease and a mortal disease from any of these causes. So take them seriously. If you get 3 of those 5 admission Rances criteria, they really ought to go to the ICU. All right, another little mental break. Anyone been up here before? This is, a couple of people. This is in Northern California, where there's a town called Weed. On YouTube, there's a whole bunch of people, or Google, a lot of people have posed in front of there, in front of that sign. And several years ago, I heard that there was a fire in the town Weed. And so I don't know if everyone got high from the smoke or what. So, okay, let's talk about. Got 10 minutes. We're going to talk about ileus, and then we'll take our break. Ileus, and then we'll talk about bowel obstruction. So ileus simply means that nothing's moving, and it's a very non-specific diagnosis. Just about anything can produce an ileus, right? Pancreatitis we talked about. An APE can produce pancreatitis. Cholecystitis can produce pancreatitis. I've seen acute coronary syndrome produce pancreatitis. UTI can produce an ileus. I've seen UTIs produce an ileus. It simply means that nothing is moving. And the result is that you'll have decreased bowel sounds, and also the x-ray is going to show dilated loops of small and large bowel. Right? If you see dilated loops of small and large bowel, almost always that's not a mechanical obstruction, it's an ileus. If it's a mechanical obstruction, you'll see, for the most part, just dilated loops of large bowel or just dilated loops of small bowel. All right? Speaking of small bowel obstruction, most common cause overall is adhesions, but don't forget about hernias. If a patient has not had a prior abdominal surgery before, hernias become the number 1 cause. And then malignancy is much further down for small bowel. Patients with small bowel obstructions tend to be much more symptomatic than large bowel obstructions. They have a lot of retching, nausea, vomiting. Large bowel obstructions tend to give you less nausea, vomiting, just more diffuse abdominal distension. All right? So small bowel patients tend to present a lot earlier, I think, because they're so symptomatic. Nowadays, a lot of small bowel obstructions get diagnosed on CT. There is this old saying that you never let the sun set on a small bowel obstruction. Well, past 10 years, I've seen a lot of sunsets on small bowel obstructions. Surgery always wants you to get the confirmatory CAT scan. For the new grads, I got to tell you, at ABEM General Hospital, the CAT scan is usually broken, and so you're going to have to get comfortable with looking at plain films that are diagnostic of small bowel obstruction. And this is about as classic as it gets. So you've got multiple air fluid levels within distended loops of small bowel. Take a look at this loop right here. See, there's a loop, there's an air fluid level there, and then the bowel goes up, and then there's another air fluid level right there. If you ever see 2 air fluid levels within the same loop of bowel, you're done. That's a small bowel obstruction until proven otherwise. So in fact, if there was nothing on this entire x-ray except for that one loop with an air fluid level there and an air fluid level right there, if that's the only thing you saw, one loop with 2 air fluid levels, that's a small bowel obstruction. All right? So 2 air fluid levels within the same loop of bowel, you're done. Call it a small bowel obstruction. Sometimes you can get that stack of coins appearance from those plicae circularis. but get comfortable with making the diagnosis and moving forward, calling surgery when you see the small bowel obstruction on a plain film, right? In terms of large bowel obstruction, remember we said small bowel obstruction, think adhesions and think hernia. Large bowel obstruction, cancer is the number one cause. There's a few others that you see up there, volvulus, diverticulitis, and so on, but cancer is going to be your number one cause. Those patients tend to have less nausea and vomiting, but much more abdominal distension. They tend to be older and maybe have some risk factors for cancer. And then there's two special types of large bowel obstruction to be aware of. These are the closed loop bowel obstruction, referring specifically to sigmoid volvulus and cecal volvulus. So I'm going to show you cecal volvulus. I'm going to show you a couple images, and we'll get to cecal volvulus in just a moment. But let me just take a moment here and summarize the differences. And you can put this in a chart if you need to help distinguish between these two. So first of all, sigmoid volvulus. Think about the woman in the upper right. Elderly, debilitated, chronic nursing home type of patient. Cecal volvulus is often a young, healthy person with no medical problems. Sigmoid volvulus is gradual onset. Cecal volvulus, this young, healthy person, bam, suddenly has abrupt onset of pain and then distension. Sigmoid volvulus, oftentimes these are chronically constipated patients, and because they're bedbound, they're constipated, they develop kind of redundant, elongated loops of bowel that one day just kind of flip over on themselves and produce the obstruction. Cecal volvulus don't have that in the history at all right? The sigmoid volvulus gives you the bent inner tube appearance, as you see up here. Looks like a gigantic inner tube, and classically it points into the right upper and left lower quadrant. That's the orientation. All right. Cecal volvulus, I've mentioned all of these things on this slide already. Cecal volvulus tends to be young, otherwise healthy, abrupt onset of symptoms, and the x-ray looks more like kidney-shaped or coffee bean off on the left side of the abdomen. All right. Now, I mentioned earlier that usually cecal volvulus is a young, otherwise healthy patient. If you look at the spine on this x-ray, this is clearly not a young, healthy patient, so I'm not sure what's going on there. But that's a pretty classic-looking x-ray for a cecal volvulus. What about treatment? Sigmoid volvulus, because it's down low, sigmoidoscopy oftentimes is effective. They can detorse the closed loop that flipped over. Cecal volvulus can't be treated from below. Cecal volvulus needs to go to the OR. All right? So again, one more time to recap. Sigmoid volvulus, elderly, debilitated, nursing home patient, largely bedbound, chronic constipation. They develop elongated loops of bowel, which flips over on itself. They come in with gradual onset of pain and distension, and it can be treated with sigmoidoscopy. Cecal volvulus, young, otherwise healthy patient, for whatever reason, the scenarios that I always hear about is a young, healthy marathon runner who, bam, suddenly develops abrupt onset of pain from out of the blue, and that can only be treated surgically. All right, and then get comfortable with looking at these plain films. Bent inner tube is sigmoid volvulus, the coffee bean shape or the kidney shape is the cecal volvulus. All right, I've just got a couple more minutes. Let's do hernias, and then we'll finish up. Just a few things to say about hernias. First of all, a little terminology. Remember the difference between incarcerated and strangulated. I hear those terms mixed up a lot. Incarcerated means the hernia is stuck, and you can't get it back. Strangulated means it's stuck, and you can't get it back, but it's also getting choked off of blood supply. All right, so strangulated hernia, you're at risk for developing necrosis of some bowel because the blood supply is cut off. Overall, the most common type of hernia is inguinal. That's true in men and women. Don't be fooled by that, all right? So most common type in men is inguinal. Most common type in women is inguinal. And we'll talk about where actually those locations are. Now, femoral is more common in women than in men. But overall, still the most common type in women is the inguinal. And the reason I'm emphasizing that is because I think a lot of people get tripped up on that on USMLEs and on the boards and in services where they say, what's the most common type of hernia in women? And people are thinking, yeah, femoral equals women, so femoral. Wrong. The most common type of hernia in women is still inguinal. It's just that when femorals occur, they more often occur in women. All right? Femoral is very important. Also, obturator hernias are important. Femoral hernias oftentimes give you upper inner thigh pain and often get misdiagnosed as a muscle strain. All right? So be on the lookout for that. If they present a patient who, it kind of sounds like they've got like a groin strain, upper inner thigh pain, sounds like a muscle strain, but there's nothing in the history that suggests they're doing any type of exercise, think about femoral hernia. All right? It's very commonly misdiagnosed as muscle strain, and if you miss a hernia, they can go on to develop strangulation and major problems. All right? Now, in terms of inguinal hernias and locations, this diagram kind of shows you where the hernias are. Indirect inguinal hernias start out lateral to the inferior epigastric vessels, then dip down, and in boys, in men, they can pass under those vessels and go all the way into the scrotal sac. All right? So if the hernia dips into the scrotal sac, that's usually an indirect inguinal hernia, which is not intuitive because it starts out lateral to those vessels and goes under all the way down medially into the scrotal sac. Whereas direct hernias start out medial to the inferior epigastric vessels and just produce bulging in the inguinal area. And then you can see where femoral hernias are. Look how easy that would be to simply call it a groin strain. All right? But if there's no history of exertion, don't call it a muscle strain. Think about femoral hernia.